So I think we'll get started. Welcome to the second end-of-life session. We have a number of great speakers. Before we get started, I did want to mention and remind you that today is Remembrance Day. And so at about 11 o'clock, we will interrupt our second speaker and have a moment of silence in recognition of Remembrance Day. So it'll be about a minute. Don't be surprised, our speaker is aware. So I think we'll get started with our first speaker. Most of you will know Sean Bagshaw. He's an associate professor in the Division of Critical Care Medicine at the University of Alberta. And he's going to talk to us about end-of-life care in the elderly.
Thanks very much. It's a pleasure to be here. And I'm going to talk a little bit about the interactions between elderly patients, the intensive care unit, and end-of-life care. I have no disclosures. So first and foremost, I think what I'll try to do is give you somewhat of a definition of what elderly is, talk a little bit about demographic transition in our society, then talk a little bit about the patterns of referral and refusal and or admission of elderly patients to the ICU, and then a little bit of data around end-of-life decision-making. So I'm going to start with a couple scenarios for you in terms of being able to define what is elderly. Scenario one is an 83-year-old male, independent, drives his car, has some chronic comorbidities, if you like, and then develops an episode of critical illness, severe community-acquired pneumonia. And I want to argue that this patient is probably chronologically old. Scenario two, on the other hand, though, is a 65-year-old male, functionally limited, mild cognitive impairment, has a similar burden of more severe comorbidities, and has the same episode of critical illness evolve. And I'd put to you that this patient may not be as chronologically old, but may be more biologically old. And I think it's important to keep these things in mind when we talk about elderly, because I don't think we can really cut it off with a single age point. Elderly consists of ages nearing or surpassing the average lifespan for human beings, and at the end of human life cycle. That's chronologic age. But senescence is something different. It's the endogenous or hereditary process of accumulation of changes to molecular and cellular structure disrupting metabolism with the passage of time, resulting in deterioration and death of the host. And this is biologic or physiologic age. And I think we probably have some appreciation of the differences between the two. But at the bedside, I think this is probably how we define them. Old age and frailty. And I think they can intersect and they can coexist, but I think there is some fundamental differences between those two. And I just want to frame that as we move forward with this presentation, that there's a lot of data that's looked at old patients, in particular chronologically old, but hasn't necessarily focused on maybe younger cohorts of patients who are physiologically old. One thing that is occurring in our society, though, is that the population is getting older. For those of you in the session this morning, Rob Fowler showed some data on this as well. And it's projected that by 2050, about 1 in 5 patients will be older than 80 years of age in the Western world. And this is the fastest growing demographic by far and away. So that portion of patients greater than 80 years of age. A few years ago, we did this study looking at the proportion of octogenarians admitted to ICU in 54 centers across Australia and New Zealand. And about 14%, or 1 in 7 of all patients admitted was in fact over 80 years of age. And that proportion was increasing by about 5% per year. And this had implications for care and resource utilization. If you looked at the referral rate for octogenarians over time in Australian population, you would see things like this: the projected increased need for ICU bed days and hospital bed days attributable to that demographic, increasing quite considerably. And in fact, if you were to show any sort of healthcare administrator these kinds of data, they would say that's not possible. We can't afford that. So these are some of the challenges that we have to consider with an aging population. The health economics of our health system, the supply is largely fixed and it's constrained, coinciding with the demand that we see is going to increase over the next 10, 15, 20, 30 years. And that has to do with demographic transition, but it also has to do with the type of care we provide patients in hospitalized settings. We certainly have more modern and more capable technological innovations to support life. And then there's been obviously some changes in patient, clinician, and societal expectations for what our healthcare systems can provide nearing the end of life. And I think Rob also showed a very elegant slide looking at the societal expectations that may be related to what people see in the lay media, specifically medical shows like ER. What's interesting, and this is a French study that looked before and after, looked at two different eras, all the octogenarians admitted during that period of time. And there's some interesting findings here. They found that 10 years later, a more modern cohort of octogenarians admitted to the ICU, these patients were sicker. They were more likely to be supported by vasopressors, mechanical ventilation, renal replacement therapy. So the intensity of their support had increased quite considerably. They were less likely to be functionally dependent. So there was some demographic transition even amongst the octogenarians that were getting into the ICU. And once they got there, they were getting more support. And interestingly as well, if you look at the outcome comparison between these two eras, those in the second era had a much lower mortality, despite the higher intensity of support provided. That's interesting. Now, it begs us to remind ourselves once in a while, why do we provide care in an ICU setting? And it's to provide comprehensive, interdisciplinary, efficient, safe, effective support for acutely ill patients, to preserve or sustain life and prevent avoidable deaths, preserve, sustain, and restore cognition and physical function for patients developing critical illness, and also quality of life. And it can be challenging for us to sometimes reconcile these goals of critical care with predicting who is ultimately going to benefit and have a reasonable prospect of substantial recovery in the context of the patient's individual preferences. And I'll come to this again later in the presentation. But what's been hinted at this morning, and I'm going to reinforce again, is that I think end-of-life decision-making, we often admit patients to the ICU who we believe have a low probability of benefit and a low prospect of recovery to leave hospital. So often in the sense that we're providing non-beneficial care to some extent. There's risks associated with ICU care, and brings up the question, do we really fully inform and get consent for patients to come into the ICU with all its bells and whistles? Because what happens to a patient when they come to the ICU when they're quite sick? Their activity is restricted, they're forced into bed, they're often restrained. They have restricted visitation, even though it's a very open model. There are times where family is not permitted to come in. We monitor them invasively. They're at risk for nosocomial infections. They have sleep deprivation. They have risk of delirium. And there's iatrogenic complications that occur as well. So the question then becomes, is there more harm than benefit in some patients? And do we necessarily restrict the patient autonomy? Sometimes the benefit seems to be questionable. And it's important, do we really fully inform our patients about what their outcome will be if they ultimately do survive in these elderly cohorts? So this is an interesting study published in JAMA not long ago, basically showing that an acute care hospitalization and or an episode of critical illness is associated with cognitive impairment and incident dementia amongst survivors. In fact, in the small group of patients who had critical illness, although it was not statistically significant, it was pretty strongly trending towards a twofold higher risk of incident dementia. And this paper just published a couple of weeks ago in the New England Journal of Medicine from Wes Eli's group, showing that an episode of critical illness is associated with cognitive impairment at 3 and 6 months. And that was modified a little bit by baseline age groups. So the older age groups were more likely to suffer this cognitive impairment. But it's not insignificant. Cognitive impairment to the point that matches with moderate traumatic brain injury and or mild dementia. And you can see that patients who had delirium, over the course of time, the longer they had delirium, the more likely they were to get this cognitive impairment. I'm not sure we inform our patients about this kind of risk. In addition, if you look at, this is another very interesting and elegant study published in JAMA. If you look at this acute care hospitalization and or a period of restricted activity, you can see that the incidence of new disability developing in our patients after this is considerably higher amongst patients who are frail, i.e. patients who have physiologic aging. And you can see the frailty was perhaps the most important modifier for new disability amongst patients who were hospitalized with acute illness. If we want to switch gears a little bit and talk about refusals to the ICU, there's some data, mostly from France, that's emerged on this that's quite interesting in my opinion. This is a study of about 600 patients referred to through the emergency department for ICU admission, and you can see that refusal was about 38%. Often it was because of futility or triage for other reasons, or they were too well to benefit. But one of the most important factors dictating who was going to be refused was older age. Patients greater than 65 had a twofold higher odds of not being admitted. Similarly, Orgas has done a lot of work around this in Paris, France, and this is a small study. 180 octogenarians referred again to the emergency through the emergency department to the ICU. And what she found was 73% were refused, which is a pretty high refusal rate. And I think it's interesting, if you just read down a little bit further, you see that about a quarter of them were informed of the triage decision. So some of them weren't even aware that ICU was considered and was refused a priori. And of these patients, of the ones that were too sick to benefit, age was a factor in 9 out of 10 of those patients. So clearly age is a modifying factor in decision-making around triage to ICU. Oops, wrong direction. And this is a similar study from the IceCube. It's a secondary analysis, but what Métis has done here is she's done a Delphi process to find out the definitive and equivocal characteristics that would define who would come into the ICU. So amongst a consensus group of emerge physicians and ICU docs, definitive criteria for ICU admission. And in this fairly large cohort, of those that had definitive criteria, only 30% were actually referred to ICU, and only 16% were ultimately admitted. And this is amongst a cohort of patients who are 80 years of age or older. And clearly the most important factors were, in fact, age and functional status of the patient. So the emergency physicians, on average, in the entire cohort, only referred about a quarter of patients, and ICU docs only took half of those, appropriately or not. Now, we've seen a little bit of this data already today. Charlie Sprung in the Eldicus study, very elegant study looking at this one focused on older age and admission to ICU. And what you can see here, it's quite interesting. You see mortality over age strata by accepted or refused to ICU. And as the age strata get older, you can see in the 65 to 74, 74 to 84, 75 to 84, and greater than 84, you can see the difference between refusal and the difference in mortality between those accepted and those refused was quite high. In fact, that was the most important difference seen in the older age groups. And the paper goes to conclude to suggest that, well, we refuse these patients, they have a high likelihood of dying. But yet those that come in have a much lower likelihood of dying. So the question is, should we be considering altering our triage criteria for elderly patients being referred to the ICU? Now, Tom Stelfox and colleagues, which I was a part of, did this study looking at ICU bed availability for a patient, ICU bed availability at the time a patient has an acute care deterioration on the ward and whether they're admitted to ICU. And clearly the study found that the fewer beds that were available, the less likely you were to be admitted to the ICU. But there was other factors at play as well, and age seemed to be one of them. So if you were older, you were less likely to be admitted to the ICU within 2 hours of your MET activation than if you were younger. In addition to that, the older patients were more likely to have their goals of care changed to one that was exclusionary of ICU support altogether, and they were more likely to die in hospital. Appropriate or not, I can't say from the data. In addition, once elderly patients do get to the ICU, and again, this is from the French group, one thing that's interesting as well, I've shown you over time that we actually may be supporting them with more higher intensity support, more renal support, more vasoactive medications, mechanical ventilation, and whatnot. But elderly patients, compared with a younger cohort that's only 65 to 79, actually do receive less intense therapy in the ICU. And that was elegantly shown in this study as well, that those patients greater than 80 years of age were less likely to receive intensity of support. They got into the ICU, but their care was somewhat limited to some extent in terms of the limitation, or in terms of the technological support or life-sustaining support provided. Now, the French have done a very interesting study as well that was published about 12 years ago in The Lancet, a large multicentric study that looked at the reasons for withholding and withdrawal of life support in intensive care. And what was interesting is there was 3 key reasons for why that was. So futility of care, the perception of, future quality of life, the perception that it was going to be poor, but also age. Age seemed to factor, and it was the 3rd most important factor for withdrawal or withholding support in French ICUs. But importantly, only 8% of patients' own willingness to limit care was known. So very few patients in that respect had been able to convey what their preferences were. In 73% of patients, they were unable to express their wishes, and less than 1% were in fact involved in the decisions to withhold or withdraw support. So this was largely going down to the medical team and/or the surrogate decision makers. And what about surrogate decision makers? This is an interesting systematic view that suggests that the accuracy of our surrogate decision makers to predict what we want at the end of life in terms of our preferences is very poor. And how about physicians? This is another one as well that looked at a cohort of ARDS patients, an agreement between surrogate decision makers and the patients in terms of their pre-morbid quality of life and function. And overall, it was generally poor. Surrogate decision makers generally perceived their loved ones as having lower health-related quality of life and function than the patients actually perceived themselves. Importantly as well, when you look at physicians' impression of elderly patients' function at the time of triage to the intensive care unit or in the emergency department, clearly factors that go into that is the evident functional status of the patient and age. Age in 40% is a strong influencing factor. But what's interesting is if you look at the measured CATS index, which is an inventory of activities of daily living, with actually the perceived CATS index between emergency physicians and patients, it's actually very poor. Very poor at predicting or actually ascertaining what's the actual function of patients. Again, this is looking at the French group in the Ice Cube study. Of all elderly patients referred to the ICU, in the end, only 12.4 were deemed eligible. And there was wide variability. We've heard a little bit about variability in end-of-life care, and I think this is a start of the intersection between the variability of end-of-life care when patients are presenting to the hospital with acute deterioration. Now, Métis Argos has also done some interesting work where she's taken elderly patients who are otherwise relatively well and gone to their homes and interviewed them and asked them, she's given them little vignettes and scenarios and asked them very detailed sort of ideas about their perceptions about what kinds of support they would want at the end of life. And specifically, she asked about invasive and non-invasive mechanical ventilation, and she asked about whether if you were mechanically ventilated and you got sicker, would you want renal replacement therapy on top of that to preserve life? And what you can see here in these colored bars, really the red represents refusal, patients saying, no, I would not want that. Whereas blue represents acceptance, yes, I would absolutely want that. And then purple represents they don't know. You can see the green represents let the physician decide, and that's uncommon amongst these patients. Purple, patients mostly had an opinion about this. But I find it interesting that, quite a few patients would want non-invasive ventilation. At least half would be interested in invasive mechanical ventilation. But beyond that, if you had invasive mechanical ventilation and you needed renal support after that, 63% refusal. Majority of patients in this sense suggested that they wouldn't want that kind of intensity of support. So some insights into patients who are otherwise well, given perspectives on what would happen if they came to the ICU. Now, how are we doing in terms of preparing patients for the end of life with respect to the interaction with critical care? This is a study that was led by Bill Sylvester at the Austin Hospital in Melbourne, looking at an interdisciplinary group that went to patients who were elderly, who were hospitalized, who were at risk for dying in the next 6 months. And the intervention here really was an advanced care plan team that sat down with the patient and the family and went through all the options and details and developed an advanced care plan versus a wild type. And I think there's some interesting insights that came from this study. First of all, of those patients approached, all of them fulfilled their advanced care plan, and their wishes were very rarely unknown. In addition to that, if you look at the location of death of these patients in the hospital, almost none of them, in fact, none of them who had the advanced care plan intervention died in the intensive care unit. Whereas if you look at those that were the wild type or control group, a larger proportion actually ultimately came to the ICU where they died. In addition to, you can see that a larger majority were involved in the end-of-life decision-making themselves. So the patients were actually given opportunity to be involved. And what's important, if you want to look at metrics that define their experience at the time of death, both with the patients and the families, satisfaction with hospital stay, with information provided, with being listened to in the hospital, at least the perception of that, and involvement in decision-making at the end of life was all much, much greater in patients who had had an advanced care plan in play prior to versus those that did not. And you've seen this data already. This is from the ACCEPT study led by Darren Halen, suggesting, how are we doing with respect to this in hospitalized patients? This is a multi-center study here in Canada looking at elderly patients at high risk of death in the subsequent 6 months as well. And it looked at both patient perceptions and family perceptions. And you can see that a minority of patients actually wanted heroic measures to be done. That's a score of 1 right there you can see on the scales. It was more or less a shared model along stream. But what's interesting is that of patients who had expressed prior wishes, only about 30% of them had actually discussed this with their GPs. And then once they were hospitalized, just over half, only 55%, had actually discussed it with their acute care team, the physicians and nurses and other allied health in charge of their current care. Given they're at risk for death, this is concerning. What was also very, very concerning was that agreement between their stated preferences based on the surveys and what was documented in the medical records was really quite poor. Only 30% actually had concordance. So that's a problem, and it sort of speaks to the idea that we have a long ways to go. So in just summary, I think we have challenges defining elderly. I think we have to integrate both chronologic and physiologic age and appreciate that there is a large transition in demographics occurring in our society. I think we can expect there's going to be a larger draw or demand on ICU services, and we need to manage those expectations and referrals. I think there is some lack of clarity about the clinical benefit of ICU at the end of life in the context of patient preferences and the risks associated with ICU. And certainly when we're not given an opportunity to ask the patients specifically about their preferences, we have to be mindful that there is a large discordance between the families and clinicians. There's wide practice variation, as I mentioned, and I think this end-of-life decision-making is quite complex. Preemptive measures, such as advanced care planning, probably need to be set as a priority and can be one thing to help alleviate the distress associated with it if there's an interaction with ICU services. And with that, I'll thank you for your time.
I think we have time for a question if there is one.
Hi.
Yeah.
Anand Kumar. Hey, Sean. How are you?
Hi, Nant.
Hey, I just wanted to, just a quick comment. I noticed one phrase that you used, and I know everybody knows this, but boy, I'll tell you, when you asked this question about would you want, or at least from the study, would you want dialysis, if you were sick to preserve your life? Can you imagine the result you'd get if you, and I don't know if that's exactly what they answered, but can you imagine the answer you'd get if you phrased it, do you want dialysis to delay your death? Right? So it's really interesting when I see these studies, it becomes incredibly sensitive to the phrasing of the question. As you know, I mean, all of us who are practicing intensivists, you could almost get whatever answer you want depending on how you phrase the question. I think the study's probably similar, don't you think?
Yeah, no, I think, and there's already been some dialogue in the first session on end of life, but framing becomes a critical issue about how we frame the interventions and or services we can provide in ICU in the context of what we expect to be the outcome of interest per se. I think that's Hannah.
Yes, Hannah Wunsch. Quick question for you. You talked about this difference between physiologic versus chronologic age, and I know you've done a lot of work around trying to measure frailty and kind of pin it down. And so I'm wondering, in your opinion, if you're seeing that patient on the ward, what do you think are some of the best markers that we should be thinking about using as maybe red flags for whether or not someone is frail and fits that criteria?
Yeah, frailty is something that I think is emerging in acute care medicine and garnering more attention. I think there's lots of different mechanisms that we can use to measure frailty in patients. Some of them are functional, some of them are cognitive, some of them are social. And it becomes challenging once patients get to hospital. A lot of the ascertainment of frailty is done in elderly outpatients who ambulate to the clinic to some extent. I think it's more challenging in hospital. I think we probably need validated metrics that we can translate into that acute care setting. We've looked at some things related to this. Things like measuring a clinical frailty scale and trying to get an estimate of trajectory in the last 6 months of life, looking at burden of disability, things that you may not need a patient to do something functional for, like patients who are sick and critically ill are not likely to get up and go and do a timed 6-minute walk or other things that might frame around a frail state. But I think increasingly, and I know some of my colleagues are doing this as well, and this is speaking from a personal point of view, trying to grasp with an index of frailty in patients in hospitalized medicine and having that modify prognostic information and decision-making is relevant and increasingly occurring. So,
Great. I think we'll move along, if that's okay with you, Sean. That's terrific. We're now going to invite James Downar to speak to us. As you know, he's both a critical care and a palliative care staff physician at the Toronto General Hospital, and he leads the postgraduate education committee of the Canadian Society for Palliative Care Physicians. He's going to talk to us about protocolization of withdrawal of care, and we will be interrupting you at 11.
Okay, yeah. Absolutely. Thank you. Oh my God, I feel like I'm being interrogated again. So thank you very much for that introduction, and there we go. no financial conflicts of interest to disclose. The objectives for today's session, first of all, to appreciate why we would need guidelines and protocols for withdrawal of life support. Secondly, to talk a little bit about the medical, legal, and ethical considerations that we should have when we are withdrawing life support from a person in the ICU. And then talk a little bit about the very limited data set that we have that could inform our practice in this area. When I think about withdrawal of life support, I think about a case that happened when I was a fellow that was quite an impactful event for me. A 28-year-old gentleman who I won't go into too many details about his care for the purpose of confidentiality, but he had a traumatic brain injury, and after 2 weeks in the ICU, he had a very poor prognosis, and there was a decision to withdraw life support made in collaboration with the family. Naturally, as many of us are aware, the family will turn to you and say, so how do we do this? What happens? And so I explained the procedure, and I talked about how we would extubate. And the family was very, very concerned about the extubation, the potential for stridor and airway obstruction after extubation. And so I tried to explore this. I tried to talk about other techniques, and ultimately we just decided we would wean to a T-piece and provide comfort measures. The family all assembled the following day when we were going to perform withdrawal of life support. They were all standing in a circle around the patient, and the members of the allied health team walked in, and one of them said, in their exact words were, "This is torture and we won't do it." And another member told the family that this was unethical. And the family got extremely upset by this experience, revoked consent for withdrawal of life support, and the patient ultimately succumbed to, we just did not escalate care, but the patient succumbed 2 weeks later. Withdrawal of life support is a highly variable practice and a way to end someone's life in the ICU, but it is fairly common, and there's a 15-year-old study now showing about a third of the cases in the US, patients die following a withdrawal of end-of-life care. That number is a little bit higher in Canada. But this study here from Prendergast shows how variable that is. So some units will withdraw in up to 80% of cases. Other units in 2 years did not withdraw once, and this is in the same country, and in some cases within the same state. Elie Azoulay presented some of this data from Europe, and again, about a third of the time this is happening, but it's highly variable by country. So when the reasons, that, of course, for variability is it has a lot to do with patient factors, but also to do with physician factors. There are a lot of associations in terms of race and ethnicity, nationality, all seem to be associated with the decision to withdraw life-sustaining measures. So it should come as no surprise to us that there is high variability in terms of how life support itself is withdrawn, even when you decide that it should be done. And there's a lot of good reasons for that. We have a lot of balance. We have to balance a number of obligations when we are withdrawing life support from a person in the ICU. We have, of course, a medical obligation to keep the patient comfortable. We also have to support the needs of the family. We have ethical obligations to avoid prolonging the dying process any longer than is necessary. We feel that's probably the wrong thing to be doing. But we know that we have competing interests. We know that our ICU occupancy is 105%, and we're always getting pressured for beds. And then, of course, there's the ugly specter of organ donation, and are we prioritizing that above the needs of our patients at times as well. And of course, there is a legal obligation to not shorten the dying process for some patients. I put 2 asterisks there, of course, because there are parts of the world where you do not have that legal obligation. And of course, there's obviously discussions about changing legislation in this country so that you would not have that obligation either. But right now, we have that obligation, and that can be difficult to balance. This was a study in CHEST from a couple of years ago showing what happened when somebody perceived that there was a trouble balancing those priorities. So there was a VA investigation into allegations after 4 people died following withdrawal of life support in the same unit. 3 of them died on the same day. And a member,
So just in respect of Remembrance Day, it's now 11 o'clock, and the whole conference will be taking a moment of silence. It'll be 60 seconds long.
Can I just wanted to show, there's
please do.
iconic poem from World War I. John McCrae, graduate of University of Toronto, grew up not far from here and studied at McGill. I usually show pictures of my family, my kids, but I decided to show pictures of my grandparents, both of whom fought in the Great War. That's my grandfather Stanley on the left, 6 weeks before he died, and my grandfather Paul on the right, holding my mom.
Wow, thank you. Oh, it's a moment of silence. Thank you, James. I wonder if you could just repeat telling us who's in the photographs, because I...
Sorry, that's my grandfather Stanley on the left. He fought in the Red Army and later for the Free Poles. And that's my grandfather Paul on the right, who was in the Royal Navy. Where was I? I didn't know where I was going to be. Thank you. I didn't know where I was going to be in the slide, so I just threw it in the middle there. There was allegations made by a member of the staff that death had been hastened through the use of high doses of narcotics and too little oxygen, and that they felt that this was due to over-prioritization of what was euphemistically referred to as patient flow for upcoming surgeries. After investigation, they felt that this was not the case, but they felt it would be beneficial to have guidelines and protocols. This issue has made it into the New York Times, where a transplant surgeon was present in the room and co-managing the end-of-life care of a person who was a potential organ donor after cardiac death. But even when there's not this sort of overt level of attention, we know from other studies that there's high variability in terms of satisfaction with the process of withdrawal of life support among allied health here in Canada, certainly, and certainly a significant amount of discomfort around withdrawal of life support among Canadian RNs and RTs, and largely that centers around just unclear plans, and people just write very unclear orders, very vague orders, and people not really sure what they should be doing. In my own institution a few years back, Neil Lazar and I did a survey where we looked at satisfaction with various aspects of end-of-life care or of withdrawal of life support. And the yellow bars on the right denote things that are done very well, the proportion that thought it was done well. Red is sort of adequate but could be improved, and blue is just very bad. And the things that were felt to be done quite poorly were things like post-mortem support for bereaved family members and things like preparing the family and psychologically preparing the patient. Things that were done well were felt to be providing adequate sedation and weaning the ventilation. But even in the high areas of high satisfaction and high competence as perceived by the allied health, there was tremendous variability and dissatisfaction with how clear the orders were. So 61% of nurses and RTs and physicians felt that doctors were writing clear orders less than half the time, and 73% favored the establishment of standardized order set. So there have been previous attempts to generate some of these standardized order sets, and I'm going to talk about probably the one that's been best documented, which is out of Seattle. They did a before-after evaluation of a WDLS protocol. They developed it using an interdisciplinary task force based on principles from a textbook written by the last speaker, Gordon Rubenfeld. I don't know if he's here yet. I couldn't see him anyway, I'm blind. The results of their study found that there was a very high degree of satisfaction among both nurses and physicians with the order set as a whole. Unfortunately, both in this study and in the big study, which has already been mentioned in the previous session, that there was no change in quality of death or dying scores following the implementation of this order set. But what was interesting is that there were significant increase in the use of opioids and benzodiazepines given, but no difference in the time to death. Just looking at various aspects of the order set itself, you can see here that people felt that the instructions about preparations and how to use sedation and analgesia were felt to be very, very helpful, and people were quite happy with them. In terms of things like principles for withdrawing life support, sadly, no one ever likes ethics. No one reads ethics. You can see the opioid orders pre-protocol and post-protocol, and one of the things you'll notice is that there was a rough doubling of the amount of medications given. What's also interesting is that there's more or less a rough doubling of the medications given after extubation as compared to pre-extubation. We're going to talk about that in a second. Jesse Delaney, who's a fellow, just finished his ICU training here in Toronto, and against my advice proceeded to go on to palliative care training as well, and he's done a literature review looking at some of the studies that have been establishing the evidence base around this area. We did, you can see the process here. It's a bit of a challenging subject to actually to study and do a good systematic review on. So we identified a number of articles in our initial screen related to the practical aspects of withdrawal of life support, and we used a pretty loose definition subjectively. But actually we identified a full extra 40 references just from looking at the references from those articles, so obviously a hard thing to encapsulate. And you can get an impression for the bottom heaviness of this study. There was 1 RCT, 3 non-randomized interventions, and 20 opinionated editorials. So, it's a whole lot of people rehashing and recycling, which I believe in environmental friendliness, but you can only recycle evidence so many times. Just going over some of the major findings from that study. Preparation things people that would routinely recommend or identify as being important would be things like a private room, liberalizing visitations, having a physician present at the bedside during the process, or certainly during key elements of the process, big time. Educating the family and trying to avoid words like agonal, as not referring to agony. Possibility of survival. Things like music and normal death rituals. I remember my favorite was we had a beach party once. The family brought in like margaritas and lays and gave everybody a lay. I personally got laid. How you get monitored, do you use subjective scales versus objective scales, and the question of whether you require bispectral EEG or some sort of other monitoring versus just using pain scales or monitoring vital signs. Is tachycardia a sign of distress? Should you be listening to the family? Should the family have an ultimate say over whether or not the person's actually in distress or not? Big question. Huge range of doses given. Typical median could be anywhere from 5 to 10 milligrams an hour of opioids pre, but some people are given as much as 340 milligrams an hour, and it doubles, as I say, post-extubation. There's a huge range of benzodiazepines, but much lower doses, 0.5 to 1 milligram an hour. Things like medications, should you be giving dexamethasone and scopolamine pre-extubation to try to avoid symptoms? A lot of controversies around whether or not to use, well, no controversy, everybody says you shouldn't use paralytics. What is the upper limit of opioids? Should there be one? Should you be anticipating symptoms or waiting till they happen and then responding to them? This fentanyl and chest rigidity thing came up a few times, and antibiotics, are they comfort-based? I'll move on because I'm just a bit running out of time here. Another big controversy is about extubation versus weaning. I'm a weaner, personally, but it's a very controversial area. One study suggesting longer survival in extubated patients, another study showing greater family satisfaction in extubated patients, but really not much else. This notion of a stuttering withdrawal, so not taking away everything at one time, but slowly taking things away over about a day, seems to be associated with a higher degree of satisfaction. But that's obviously associated with the finding that many therapies will continue right throughout withdrawal of life support until death. There's an interesting study showing about the order in which things are withdrawn. So things that seem to be more artificial or more costly withdrawn early, but things like IV fluids and tube feedings may not be withdrawn at all, or would be done so very, very late in the day. Suggested weaning orders. The role of allied health was, there's not a lot of evidence around that, but certainly a lot of comments about how important the nurses' role are in terms of support and education, particularly in the LTACs in the US, where the nurses tend to be more involved in running the unit and patient care. And then there was the question about whether you need a routine debriefing after every death. Should this be just a PRN thing, or should you actually schedule one each time to discuss the morale of the unit and moral distress and satisfaction? Bereavement. Huge gaping hole in our research and understanding. Education about what is normal and abnormal grief. Should you send a letter of condolence? And should there be a routine follow-up call? Is anyone actually screening for this? No. The ethics. The ethics underpinning this, of course, there's two major principles. One is the doctrine of the notion that withholding and withdrawal are identical, or equivalent, I should say, morally, ethically. Not everybody agrees with that. The doctrine of double effect, which is that you can have two effects from an action, one that causes comfort and one that may shorten life, and it's okay as long as the one you're intending is acceptable. But it's interesting that there are actually no studies that have ever shown a link between opioid doses and duration of survival, and some suggesting longer survival with higher benzo use. There was a notion in Japan of these soft landings, that you don't do anything sudden, just infusions and steadiness so that nothing looks like it caused the death of the patient. Importance of documentation. Interesting comments from Charlie Sprung and the ethicists about the use of medications for shortening the dying process. This was documented even when it was illegal to do so in many of these countries. But when you actually drill down and look at what doses the patients were given, in most cases these doses were entirely consistent with comfort care. So this is probably more related to a misperception on the part of physicians that opioids cause death, not necessarily the intent to cause death. Some cases people were supposedly killed with 5 milligrams of morphine. I think if you think you're killing somebody with 5 milligrams of morphine, I think you need to read more about euthanasia or more about morphine. So anyway, the objectives today were really to talk about the need for guidelines, to understand some of the considerations in withdrawal, and of course to be familiar with the data. And I want to thank you for your attention and acknowledge Jesse Delaney and Tracy Bailey, lawyer, who's going to be participating in the workshop. Thank you.
Thanks, James. That was outstanding. We do have time for a couple of questions if there's
While people are coming up, I just want to say, if anyone is involved in the workshop at noon, it's extremely hidden location. I apologize. It's on the mezzanine floor, which is one floor above the lobby. You can't get there from the front. You have to get there from the back. So behind the restaurant, there's stairways to go up, and it's way in the back. Conference B and C. If you can try to follow me, I will lead like Moses.
Brenda Morgan from London,
Hi, Brenda.
Ontario. That was great. Thanks
Thank you.
very much. But I wondered if I could just clarify one point, because I've heard it several times at this conference. Nursing is not allied health. It's unique, and I think that's really important when you're looking at the experience of nurses in withdrawal of life support. It's going to be different than the respiratory therapist. So nursing is actually not part of allied health. It's a separate discipline.
Thank you very much for that. I certainly didn't mean to sort of say that there's physicians and then there's everybody else who's sort of modular and interchangeable. Everybody. I'm sorry if I gave that impression. That was not at all intended. Everybody plays a very unique role. We're a team, and we should be thought of that way. Thank you.
Hi, I'm Daniel Garros from Edmonton.
Hi, Daniel.
You have a halo. I'm just astonished that my adult colleagues are still so behind on this issue of ICU open doors, bereavement follow-up. We have been doing this in pediatrics for the last probably 15 years, and there's excellent evidence how important that is for the families, how important a letter from the physician is. There is strong evidence now on the fact that if the doctors show some emotion at the end of life, the actually bereavement of the family is better. And my question to you is the protocolizing of end-of-life withdrawal. We tried to implement this in my ICU, and the first reaction from my colleagues was, "Are you nuts? Every family is different. How can you protocolize how you're going to withdraw?" Some families, and we offer that all the time, do you want to lay down with your child in the bed? My research at CKids, when we did this, 75% of the families either held or laid down beside their loved one, but 35% that we offer did not want that. So it's so different from one family to the other. I agree with you that we need to have some guidelines and some principles. But my question to you, after this long commentary, is do we really need to do kind of a step-by-step, or it's just principles and we should apply individualization for each patient?
I would say the answer to both, I think yes and yes. The short answer to that is I think protocols can be very helpful to remind people of things like the option of getting in bed with a child, or doing any number of other things that might not occur to people if they hadn't heard it suggested. All of these things sound great in retrospect, but I mean, imagine, I'm just saying, if someone called you from an ICU, a friend of yours, and said, "Hey, I got to withdraw on somebody, what should I write in the chart?" What would you say? And just whatever you would answer, the best advice you would give, why not simply write that down in a protocol?
Thanks, James. I think we need to move on.
Yep.
So our next speaker this morning will be Jeremy Kahn. Jeremy's an associate professor of critical care medicine, and health policy at the University of Pittsburgh School of Medicine and Graduate School of Public Health, and he's a core member of the Charisma Laboratory in Pittsburgh as well. And Jeremy's going to speaking to us this morning about measuring the quality of end-of-life care. Welcome.
Thank you so much, and I hope you guys are enjoying this wonderful session as much as I am. It's really been a terrific day. The topic I'm going to be talking about is the quality of end-of-life care, and whether or not we should be using this as a quality measure as we do in other domains of healthcare. The first question that we need to answer when we're thinking about should we be measuring quality is why of end-of-life care is why do we measure quality of care at all? It's a pretty straightforward list, and it's a fairly simple list. Internal benchmarking is probably the most common reason, right? We want to understand our own practice, and in order to do that, we have to measure it. We can't improve what we don't measure. Measuring quality of care is essential for the practice of quality improvement, and then there's these sort of externalities, these extra incentives that healthcare payers and governments and hospitals and others want to enforce on us, which are quite valid, things like pay for reporting and public performance. Here are two articles I'd point you to just to get a better sense of these ideas. The top one was in Critical Care Medicine a few years back, sort of outlining the role of quality measurement in day-to-day quality improvement. The bottom one is a statement from the American Thoracic Society that said, although sort of as clinicians we often resist this idea that we should be compensated more for higher quality, so-called pay for performance because of the risks, it is actually quite legitimate on the part of people who are purchasing healthcare to say, why should we pay the same for poor and good and healthcare? We should actually reimburse high-quality providers more and low-quality providers less, and that's actually quite a reasonable assumption, and it can be, if applied validly, quite useful for informing quality improvement. The next question we have to ask ourselves is how we measure quality. And this is a very pervasive framework for thinking about quality of care. It's now almost 40 years old, and it's really stood the test of time. Downar first put it forward back in 1978. He said there's 3 domains of healthcare quality: structure, process, and outcome. Process is the degree to which care best aligns with evidence-based practices. Outcome is the degree to which care delivers patient-centered outcomes. And the structure of care is how care is organized and managed to best deliver the other 2 domains. Outcomes are the things we care about, and in critical care in particular, there's actually a quite limited set of patient-centered outcome measures. Mortality is obviously the important one, right? We want patients to live at the end of the day. Quality of life, family satisfaction, costs are not really a patient-centered outcome, but more a societal-centered outcome. And the last one is quality of death and dying. Again, part of this quite limited subset of patient-centered outcomes in critical care. So we should be measuring these things when the following conditions are true. We should be measuring these things when they're important to patients, when we're able to measure them, and when the benefits of measuring them outweigh the drawbacks, outweigh the risks of measuring. And I'm going to walk through each of these sort of 3 categories and reflect, does quality of death and dying, or does the quality of end-of-life care apply to each of those 3 domains? And my answer will be yes. So first, is it important to patients? I think the answer to this is obvious, and most of the talks from the early morning session and this session have really driven this point home. I'll just bring up a couple studies, some of which have been mentioned before, but some of which are new to this session, hopefully convincing you that patients do indeed value a good death. This is a really nice study, sort of asking patients, family, physicians, and other care providers, what do you think is important at the end of life? The most universally endorsed factor was the ability to name their own decision maker. So to have some autonomy at the end of life by indicating who is going to make decisions for them. But the next 2 most important ones were to be free of pain and to be free of shortness of breath. Presence of the family, the next most important one, was actually quite lower down on the list. So again, very, very highly patients value having a good death. And just as importantly, patients are willing to trade life longevity in order to gain quality of death and dying. This is a nice econometric study looking at this trade-off. They interviewed patients with chronic diseases and found that 75% were actually willing to shorten life in order to gain a quality end of life. A quality dying experience was worth a shorter life. And the median trade-off here was not trivial. It was almost 8 months. People were saying, I want a good death to the point that I'm willing to live 8 months shorter at the median. So hopefully I've convinced you, and I think this crowd probably needs very little convincing, that a high-quality death is important to patients. This is the next criteria. Are we able to measure the quality of death and dying? Much, much harder, but I'm going to argue yes. This is now 6 years old. It's from the Robert Wood Johnson Foundation in the United States that says, let's propose some quality measures, some metrics for the quality of death and dying specific to critical care. They outline several quality metrics along 5 domains: decision-making, communication, continuity, support, and symptom management. And we can question the merits or drawbacks of all of these, but generally I think we would agree, looking at this list, that they're pretty good. Assessing the capacity and identification of a surrogate, highly rated as important by patients, a good quality measure. Documenting advanced directives and goal, timely communication, a timely conference, transition of key information when the patient is in the ICU and leaving the ICU, policies for nursing continuity, open visitation policy, documentation of support, and then pain relief, and then indeed having a protocol for withdrawal of life support, even in 2006, was endorsed as a potential quality metric. There are some other ones. I'll show you some endorsed by the National Quality Forum. This is a US-based clearinghouse for quality measures. They have sort of 4 criteria for what they consider to be an acceptable quality measure. It has to be important to patients. It has to have scientific acceptability. This is things like reliability and validity. It has to have usability. We have to be able to implement it. And it has to be feasible. We have to be able to act on it. They very recently called together a stakeholder conference to revisit and codify their end-of-life quality measures. They came up with 4, some that are specific for oncology patients, so dying from cancer but are admitted to the ICU in the last 30 days. They want that percentage to be lower, although not necessarily 0. Percentage of patients who die from cancer not admitted to hospice, they also want that to be low. Percentage of ICU admissions in which care preferences are documented in the first 48 hours, tremendous face validity there, and that overlaps with the RWJ recommendations, and then percentage of pediatric ICU patients receiving pain assessment. We could think of a lot more. They identified these because they had already been sort of developed and vetted by various quality improvement organizations. There are other potential domains. One I want to raise, which is the idea of let's just measure the quality of end-of-life care directly, because there are instruments for this. One developed by Randy Curtis in Seattle, the so-called quality of death and dying score. It has decent but not ideal psychometric properties. It runs up against a lot of limitations. The reliability, this is essentially a survey given to caregivers and family members around the death process, and you end up getting a score from 0 to 100, 100 being ideal. This was the development range, but in subsequent studies, it's got what we would call ceiling effects, meaning that actually a lot of families rate the quality of death and dying very high. That sounds great, but if everyone is having an ideal quality of death and dying experience, there's nothing to improve upon, and that's the so-called ceiling effect. But also the reliability here is imperfect, and this is probably not ready for use in quality improvement, but is still limited to the research field. I think there are a substantial number of quality metrics that I've outlined before that have a fair amount of face validity. So here's the meat of what I want to mention, which is, do the benefits outweigh the risks? We don't like to measure quality when we can actually end up harming patients rather than helping patients. And there's lots of examples in the medical literature about how quality measurement and quality improvement have done more harm than good. Some classic examples from the US are our experience reporting cabbage, 30-day mortality rates in cabbage. In New York State, when this happened, cabbage mortality rates went down. But when they looked a little closer, surgeons were upcoding comorbidities, so making it appear as if patients were sicker. That's not helping anyone. They were also avoiding operating on high-risk patients, and a lot of those patients had to leave New York State to get care. It turned out a lot of those high-risk patients were minorities, were African Americans, so we were actually creating a disparity in access to care by measuring quality. So do the benefits outweigh the risk? And here I would turn it on its head and say, actually not measuring the quality of end-of-life care is doing way more harm than good. Because this is what we are measuring, right? We're measuring mortality. And mortality as a quality measure has a really specific problem in that many ICU deaths are what we would call preference-sensitive deaths, right? We're very good at critical care. We're probably too good. I can keep pretty much anyone alive for a sustained period of time. And so because of that, the dying experience in the ICU is now largely about withdrawal of life support, and I can delay that. And if you're benchmarking me for, say, 30-day mortality, then I can affect that by keeping patients alive longer than 30 days. And in fact, there are some data in New York State that this occurred with cabbage patients. Because of that, existing mortality measures can incentivize poor quality end-of-life care. So by overemphasizing mortality and by just calling mortality mortality, right, we don't distinguish between a so-called good death and a so-called bad death, although all of us in our head have that construct, we can sort of know it when we see it, we might be incentivizing these bad kind of death. Now, this is a really powerful concept. Like, I think we all believe that it's probably true. There's not a ton of data on this. There's a lot of anecdotal reports. I'll just give you one right across the border. This hospital, Mercy Hospital in Buffalo, back in 2000 6 was declared one of the worst hospitals in America because it had a way higher CHF mortality, 16.4% than the national average. This was humiliating for the hospital. But when they dug down to it, actually a lot of those patients were already enrolled in hospice or palliative care before admission to the hospital. So these patients were admitted to the hospital for palliation and the intent was that they should die a good death, but they were showing up as black marks on this hospital's report card. And indeed, if you took those deaths out of their report card, this, one of the worst hospitals in America, actually became one of the best hospitals in America. So a specific anecdote, not a lot of data, but a nice anecdote to show these risks. Here's some data we have from Pennsylvania that are in preparation. We looked at Pennsylvania teaching hospitals, and we matched hospitals that have the same risk-adjusted mortality. Okay, so if you look at a traditional ICU quality metric, these ICUs, these hospitals are the same. And there's substantial variation in the dying process within those hospitals. The sort of mean values for hospitals in what we call the A category, if you died in this hospital, you were very likely to not be in the ICU and not receive mechanical ventilation. If you died in a B hospital, on the other hand, you were much less likely to not be in the ICU. You were more likely to die on mechanical ventilation and more likely to die with a trach. So again, just because we can say two hospitals look the same from a mortality perspective, they actually might be quite different in terms of the dying experience. And our current mortality measures are neglecting that and likely incentivizing very intense, poor quality end-of-life care. And that's why I think rather than say to ourselves, man, there are risks to measuring the quality of death and dying, we should say we're already measuring quality of care in a way that's incentivizing poor quality of death and dying, and we need to change that. A couple risks that are, I think, legitimate. One is this idea of improving documentation rather than improving quality. If my quality metric is document that I discussed preferences with the patient family, I'm just going to document that I discussed preferences with the patient's family. I might not actually do it. Neglecting unmeasured care. There are lots of things about high quality death and dying that we can't measure, and we don't want to neglect those in our rush to measure the ones we can. And then minimizing the role in ICU palliation, and I think this is probably the biggest risk, especially when you say you have a good quality of death when you don't die in the ICU, because one of the lessons of the support study you guys are familiar with, and I think a frame shift in ICU care in the last 20 years, is that we can provide very high quality end-of-life care in the ICU. And if I'm going to be benchmarked on keeping my decedents out of the ICU, we might be missing an opportunity to provide high quality care. Two limitations that I'll briefly mention. We still, I think, kind of lack meaningful targets, and then there are some political considerations. Eli Azaleh showed this slide in the earlier session to just show this really high quality, multi-component education and academic detailing intervention to improve end-of-life care in the Seattle area did not. And in fact, some aspects actually went down. There were fewer family conferences after the intervention. And we can debate the reasons why this is, but suffice it to say, there are many scenarios where sort of the best of the best QI didn't succeed, so we're not quite sure how. I think probably the answer is we need more specific patient-tailored education and not sort of these broad ICU-tailored education initiatives, and we are studying that in Pittsburgh. And then this was a really nice study that we talked about this morning. I'm not going to harp on it, but unclear if these results could be replicated in other healthcare systems. Political considerations are largely going to be coming in the next talk, but just suffice it to say, especially in the US, whenever you start talking about measuring the quality of end-of-life care, people get their, get all up in arms. So we have to be respectful of differing opinions as we address this issue, but I think some of these political considerations are addressable. So to wrap up, I think we should measure quality of care when it's important and it's able to be measured, and I do think that the quality of end-of-life care meets those criteria. I think the alternative is just untenable, and we can't sit by and benchmark hospitals and ICUs based on solely mortality as an outcome measure, because that's going to have the wrong effect. We need to measure this to make those measures even better. We do need research to identify the targets, and here, and this will be my concluding sort of statement, I think it's really important, don't let perfect be the enemy of the good. In quality measurement, in general in healthcare, we tend to freak out about the unintended consequences and downplay the positive benefits. And we say we don't want to do quality measurement until we've got it perfect. And I think that that's wrong, and we're probably delaying and missing an opportunity to improve the quality of care. We're not going to be able to do this perfectly for another 10, 20 years, but until then, there is a lot we can do. Thank you so much.
We have time for one or two questions.
Thank you very much. Very important talk. I'm just going to ask a question about the concept of healthcare delivered in a linear fashion as opposed to appreciating the complexity of the care we provide. In particular, if we're looking at the outcome measures that you've listed, like decision-making, communication, continuity, support, symptom management. First of all, our patients don't give us a record of their comfort during their dying experience. So saying that we are looking at that, we can't. For the vast majority of our ICU patients, and we know our surrogates of either the nurses, physicians, family members don't give the same reports, so that at this moment we don't have a measure to measure that. Communication. We know that better communication if the patient the physician gives a good outcome, then they're perceived as being better communicators. And so family satisfaction, really, how do we really measure that as a quality indicator? You know, these are just a couple, I could just go down and just finish and I won't, but this notion that we have good markers already to use, I think is too simple and linear as opposed to appreciating the complexity of the situation. I wonder if you can comment on that.
Yeah, I sort of agree, and I think this is one of the failures with the outcome measures that Randy Curtis has developed, the quality of death and dying survey. There's poor reliability between providers. We obviously can't ask the patient, how was your death? Maybe the technology could really advance and we might be able to, but that's obviously a long wish away. But in the absence of these high quality outcome measures, I think it is reasonable to focus on process measures, meaning that I don't know whether the patient was certainly in pain or not, but I can document that I assessed pain using a very structured approach, and I responded to that assessment with pain medicines if indicated, as opposed to the opposite, which is I failed to routinely and systematically assess pain. And so if we rely on the process, we're going to have to accept that process outcome link. Other quality measures we haven't had to. For example, we often rely on process quality measures in the ICU, like elevating the head of the bed. We assume that there's a process outcome link. If I elevate the head of the bed, I can reduce VAP and I can improve mortality. And there are RCTs that demonstrate that link. We're never going to have those RCTs in end-of-life care, but that shouldn't stop us from using process measures as a solid surrogate for outcome measures because the alternative is untenable. This idea that, family satisfaction, I agree. Sometimes I think we want an unsatisfied family because to make a family completely satisfied, this isn't a cafeteria. I can't give them everything they want. But that's the inherent challenge here. I think it's a surmountable challenge, but I really agree with your points.
I think using process measures is an important place to start, as opposed to.
Well, thank you very much, Jeremy. That's
thank you all.
Excellent. Thank you.
Our final speaker for this morning's session will be Gordon Rubenfeld, who is the Chief of the Trauma Emergency Medicine and Critical Care Programs at Sunnybrook Health Science Center, and he's a Professor of Medicine at the U of T. Obviously, we know his broad research interests, but one of which is end-of-life care issues in the ICU, and he's going to speak to us about end-of-life and the media. Welcome.
Yeah, thanks. So one of my colleagues, Damon Scales, accuses me of actually never giving the lecture that I've been invited to give, but just more or less what I want to talk about. This is kind of a little bit of both. So I'd love to get up here and tell you that I have a lot of experience with speaking to the media about end-of-life care. Unfortunately, as you all know, I've been involved with a pretty high-profile case of late and more or less haven't been able to engage with the media about this despite really, really, really wanting to. So my media exposure to them is actually pretty limited. So what I'm going to do is more or less talk about some aspects of the Razzouli case that I don't think have come out in the media and I think should have come out in the media. I'll go on and further and say that there are some aspects of this case that should have been made more explicit by colleagues in my field that I think haven't been. So we can have a discourse about that as well. I shouldn't have to make these following points, but I will anyway, as preparatory comments. Conflict around life support is incredibly rare. We have a huge availability heuristic, which means we sort of remember a case. We can all remember very, very challenging cases around this, so we tend to overestimate how frequent these are. And I think we tend to underestimate how fulfilling and compassionate and satisfying a lot of the end-of-life care that we provide is. They are rare, they should be rarer, for a variety of reasons, including our increased technologic capabilities, the aging population, and the increased diversity of patients in Canada. I think they're going to become more common. Obviously, I shouldn't have to say, we all agree that the most important issue is getting better at the skills of compassionate negotiation rather than legal resolution or even procedural resolution. And finally, I think it goes completely without saying that families and our patients remain the most important focus of medicine, rather than the who gets to decide, as it's been portrayed in the media. I will say that this is the paper I'm happiest to be senior author on. It's frequently cited as Cuthbertson v. Rizzulli, and I also want to acknowledge the fortitude of Brian Cuthbertson, because I think he's more or less taken a lot of the public focus of this case. And it's definitely been an interesting experience from us. I also appreciate all of the notes of support from all of you in the audience and people in our field, although I have to say I found them a bit odd, because throughout this whole experience, I've really felt that this is really just an issue around, as I'll tell you, an issue around legal clarification. I don't really feel like I've been the standard bearer for some unilateral right of physicians to make decisions, but really just an important legal issue that needed to be clarified. So I haven't really felt put upon, but I definitely appreciate your support and the nice emails that people have sent. So what I'd like to talk a little bit about, for people who don't know, the Rizzulli case, and I'm only telling you issues that have been made public through the media and the courts, is about essentially a patient who had a complication after brain surgery and developed ventriculitis, and initially diagnosed as persistent vegetative state and subsequently at the lowest end of minimally conscious state by functional imaging and EEG. And remains ventilator dependent. And the issue was about whether or not consent is required to withdraw mechanical ventilation, whether it was a standard of care issue, and if there are disagreements, whether it should be resolved in the courts or through the Consent Capacity Board. Unfortunately, the way this is all played out is it's played out as the doctors demanding the right to unilaterally make treatment decisions. The other issue that's come up is, hey, we already know how to manage these cases of conflict. They should go to the Consent Capacity Board. Why was this case even needed? What was the issue here? We know the answer to this. And finally, rationing, which has come up in a lot of the media stuff. Okay, it turns out the reason why all that stuff is in the media is because what the case is really about is actually kind of technical and a little boring. What the case is actually about is to define the word treatment in the Healthcare and Consent Act. Because it's a treatment that's being offered is what you need consent to do. Consent from somebody, consent from a surrogate, from the patient, or in their absence, the Consent Capacity Board. And the whole issue was whether stopping a treatment is itself a treatment. That's kind of, it sounds like very legalistic and scholastic. That's what this case is about. Peripherally or tangentially related to that is the question there implicit in that, are there any decisions about life support, any at all, where the issue is not consent or best interest, but the standard of care? Are there anything? Can you imagine any decision that is so clear about life support where it's a standard of care issue and not an issue of consent? So there was that question. And we thought withdrawal of mechanical ventilation in a PVS or MCS was about as close as you can come to clarifying that question for a court. And if so, the argument wasn't, oh, doctors get to choose. If so, the argument is if this is a standard of care question and there's a debate about the standard of care, then it ought to be resolved in a court of law rather than a Consent Capacity Board where the issue might be consent. So those were the questions. And we did not already know the answer to those questions. How do I know we don't already know the answer to the questions? Because the University of Toronto Centre for Ethics met, maybe some of you were involved in this, their task force on critical care, met 12 years ago and said that these issues were still unclear about which issues needed to go to court, which issues needed to go to the consent capacity, and what the standard of care was. So 12 years ago, it wasn't clear. And because nobody had pressed the issue or asked the questions, 12 years later, it still wasn't clear. So it wasn't clear. How else do I know that we didn't already know the answer? Because 2 judges of the Supreme Court of Canada disagreed. So there was a disagreement within the court. So these questions were not completely clear in advance of this case. They may be legalistic and they may be a bit boring compared to rationing and doctors versus patient, but they certainly were not clear. I also pointed out, and I'm only told this by legal experts, that the 2 dissenting judges are both Ontario judges who arguably have the most experience with the Consent Capacity Board and the most knowledge of the Healthcare and Consent Act, and they were the 2 dissenting judges. And it's not about rationing. It really isn't. As much as you want this to be about rationing and cost savings, the data to support that argument are negligible. This is something that John Luce and I wrote some years ago, and the data, if anything, now are even more supportive. If the number of these cases are too rare, so that if we converted all of these patients to palliative care, that would be able to rescue and bend what we talk about, bending the cost curve of healthcare. These cases are not the situation where we're going to save Canadian healthcare on. In fact, these data apply to the US, but they're sobering numbers. Unnecessary image dollars wasted in the US, $33 billion a year. Unnecessary spinal fusion, $11 billion. Unnecessary antibiotics, $500 million. And when my colleague Randy Curtis tried to come up with a number for how much money could be saved from appropriate rationing of care from elderly patients, this was the big number he came up with. And I submit to you, that's not low-hanging fruit. Getting rid of unnecessary MRIs is a lot ethically less challenging than the sorts of issues we're talking about in saving dollars. However, in Canada, I don't think it's about the dollars, so there's not a huge amount of money to be saved here, but in Canada, as opposed to the US, we're dealing with a fixed resource, namely the ICU bed. I think these are fundamentally different arguments. So it's not we're going to save a whole bunch of money by limiting this care, but the issue to access to a limited resource is a big deal. So in the US, which is heavily ICU bedded, and actually probably has more ventilator-capable beds than this classic slide from Hannah Wunsch shows, and operates routinely at somewhere between 60 to 80% occupancy for their ICU beds, having a burden of these patients in the ICU does not impair access. In Canada, I'm not so sure. And I think those are studies that need to be done. But I think it's an important distinction. So what are some of the implications of the Rizzulli decision that I think have been overlooked? So number one is it's the end of 20 years of palliative care integration. I'll tell you what I mean. The Rizzulli Court, for the first time in Western jurisprudence and bioethics, has introduced a legal distinction between withholding and withdrawal. And I'm going to tell you how big a deal that is, how revolutionary it is, and how problematic it likely is. The Rizzulli decision says that the medical standard of care is irrelevant for decisions to stop treatments, which are determined by best interest standard. Now, I don't know that this is good or bad, but it's interesting that the medical standard of treatment is actually irrelevant for the decision to stop a treatment. I think that would strike a lot of doctors as being interesting. And it raises some interesting case questions. All right, number one. So for 20 years, my colleagues in palliative care, and one of my longstanding colleagues you've heard referenced many times this morning, Randy Curtis, has been teaching me. In fact, we had a very big grant called Integrating Palliative and Critical Care. So palliative care physicians have been teaching us for 20 years now that it's a mistake to think about stopping curative therapy and then starting palliative care, right? That's wrong. The idea is you integrate palliative care through the continuum of care, whether it's during chemotherapy or in the ICU. And I think this is what we all more or less do. However, you need to know the Supreme Court of Canada doesn't think palliative care works that way. In fact, a major part of the reasoning in the Court of Appeals ruling and the Supreme Court ruling was that the reason why stopping a ventilator was a new treatment is because to stop the ventilator, you had to start this brand new treatment called palliative care. Thank you. So if I were a palliative care doctor, I'd be freaking out. What do you mean? Why are you telling doctors not to start palliative care until they turn off ventilators? So this is a complete misunderstanding of what palliative care is. And again, I think more or less sets the field back quite a bit if I think this would have a big impact on the way that people thought. Now, what about this withhold versus withdraw issue? The standard thinking for us has always been withholding and withdrawal, they may feel different, they may be psychologically different, there may be some religious views that view them as very differently, but from a Western bioethics, legal and ethical standpoint, they should be treated equally. So this is 1983, the classic document from the US that really first started struggling and clarifying these issues. They wrote in 1983, and there hasn't been a dissenting argument to this that I know of, or a dissenting legal case that I know of. Adopting the opposite view that treatment once started cannot be stopped, or that stopping requires much greater justification, say for example you need consent to stop, but you don't need consent to withhold, that would be a differential justification, is likely to have serious adverse consequences. Treatment might be continued for longer than is optimal for the patient, even to the point where it is causing positive harm with little or no compensating benefit. And they go on further to say the bigger concern is that physicians will now, if they're afraid once you start something you won't be able to stop it, physicians will be less likely to offer a trial of intensive care. And what I'm further worried about is the potential for invoking other variables like race, age, underlying diagnosis, et cetera, for this decision not to offer a trial of intensive care. This is well known, this concern about this. And they conclude, ironically, if there's any call to draw a moral distinction between withholding and withdrawing, it generally cuts the opposite way. Greater justification ought to be required to withhold than to withdraw. The doors to the ICU should be wide open, because we should be able to offer trials of intensive care, which is frequently the only way we know it. That is no longer, at least from my understanding, and I should have introduced this whole as a caveat that I'm not a lawyer, based on my understanding, that is no longer the law in Canada. It's now very clear that you need consent to withdraw life support, not so clear the procedures around withholding. The standard of care is not relevant. So this is a very interesting paragraph. The issue here is not the correctness of the physician's professional opinion that sustaining life in Mr. Razzuli's situation confers no medical benefit. In fact, their opinion appears to reflect a widely accepted view in the medical community. The issue at this stage of the argument is whether maintaining Mr. Razzuli's life serves a health-related purpose within the meaning of the HCCA. So this is the court, in my opinion, avoiding the bigger principles and important issues and ideas and saying we're just going to rule on the Webster's definition of treatment and apply it to the HCCA. By the way, I have no issue with the decision that says that the medical professional's judgment about therapy indication is not relevant for a particular therapy. It seems to me to be unique, and I'm not a lawyer, and I wanted to share that observation with all of you so that you know what the law says. So which treatments can be stopped? Now, one of the arguments that were made to the court is, okay, if you need consent to stop a treatment, well, which treatments do you need consent to stop? If I have a patient on an outpatient who's on an opiate, and they feel it's in their best interest to continue the opiate, and I feel it's not, am I allowed to stop it? Do I need their consent to stop the opiate? If a patient's on chemotherapy, and it's clearly not working, their tumor's getting larger, and the patient comes in and says, I say to them, I'm sorry, this drug isn't working, we're going to stop this, and we're going to shift you to some more comfort measures. And they say, you know what, doc, I'm not ready to give up yet. Explain to them that you're not giving up, and they say, I'm really not ready to give up. Are you obliged as an oncologist to get consent to stop the radiation or the chemotherapy, even if it's causing harm? So the court was pretty smart about this. Except they were smart, but in a way not terribly helpful. Because what they said was a more nuanced view that withdrawal of treatment may sometimes, although not always, constitute treatment, better fits the provisions of the HCCA and the realities of medical care. So what they're saying is, some of these treatments you need consent to stop, some of them you don't. We've got some guidance here. For sure, ventilators count as ones you need consent to stop, but it's not so clear which ones. require consent to stop and which ones don't. I'm sure all of our lawyers will be helping us try to tease through that argument. But I'll tell you some ones that pretty clearly apply, in my opinion, that are rare, I think, but strange, that clearly come under this. Are you allowed to stop ECLS when a patient that was initiated as a bridge to transplant, when the patient is no longer eligible for transplant, if the family and the patient doesn't want to come off, period? The answer is, I would think, no. You need consent to do that. How about in the OR, in those rare situations when the heart can't be restarted and patient's on bypass? Surgeon needs to break scrub, come out, tell the family and get consent, I would imagine, get consent to stop cardiac bypass. An incredibly rare event, but I think an interesting implication of this. One that's a bit more common is, we used to have the right to stop CPR. Are we allowed to stop CPR? Like, just stop CPR. Do we need consent to stop CPR? The patient's not dead until you stop CPR and declare them dead. They arguably have a pulse while you're doing CPR. In what way is CPR not life support that needs consent to be stopped? I mean, the fact that it's a silly question begs the point, right? Hopefully we've learned enough about that so far. So I don't know the answers to these questions, but I'm just pointing out some of these scenarios to all of you. I do want to say, I thought I'd updated this to make one other small point that I actually think may not be so small. We all have encountered families in the ICU, and it's a terrible situation where they actually agree with us that their loved one would not want ongoing life support in this situation. They agree with us. We've grieved together, we've cried together, we've reached that situation, and families will say to me, but you know, Dr. Rubenfeld, I just can't say those words. It feels like killing my mom. And in those situations, I have been able in the past to say, you don't have to say those words. This is what I'm saying we're doing. And you get that sigh of relief. I think we've all been there. I think we've all used this tool. We are no longer allowed to use that tool. Families now have to say the word, at least as I understand it. They now have to consent to the withdrawal of life support. So for that family where we have in the past used the tool of saying, no, I don't want you to feel guilty. I want you to understand that this is my recommendation. This is my plan. In my opinion, and again, I would hasten to say one more time that I'm not a lawyer, that is not consent. And that's what we now need to withdraw life support. So I think that this has been an interesting journey for me, and I do appreciate the opportunity to sort of illustrate some of the issues that I think haven't really come out in the media. And I do value all of the support and interaction and engagement from all of our colleagues. I think that we need to continue to remain engaged. I think people need to continue to understand this decision. And where necessary in your various provinces, when in those rare situations where there really is irreconcilable conflict, to move these cases forward so that we can make them public and understand them all together better. Thanks very much.
I think we're going to take some time for questions. This is obviously a very important issue. It was covered extremely well, but we will be finishing on time. So please be aware of that, and I'll have to cut off questions at some point. But
questions, yes or no?
Sure. Go ahead. Yeah.
Sorry. All right. I disagree with you. As you know, we had our own issues with stuff like this, and I think the decision on the Rizzulli case parallels completely the rationale they gave for giving an injunction against the Golubchuk case. It's completely parallel. But I would argue with you that the current law is that you have to get an explicit consent. I think you have to accept that. What we'll do is we'll say basically this will be our decision kind of thing in the kind of circumstance you describe. But if you want to try to override us, this is how you do it. I think as physicians, you may be right. We say, look, speak to hospital administration kind of thing. You may be right in terms of
the law,
the law kind of thing. But the fact of the matter is, we make decisions all the time where we take some minuscule amount of risk.
Oh.
That's it. So I'm not a lawyer, and neither of us are, and I'm not here to give legal advice. I'm here to. I think we take minimal risk of. I think the concerns about legal liability in general may in fact be overplayed for a lot of these issues. They certainly are in the U.S., and I suspect they are in Canada as well. I'm not here to tell people how to move the field forward. I'm telling you what I think consent is, and you can sue me if this isn't what you want to do. I'm sorry, isn't consent. And the law requires consent. I'm not saying that that's an inappropriate approach, and you can certainly do that, but the law requires consent, and again, I'm not sure, this is what we're going to do unless you sue us, is not consent. But I may not look, I thought I understood what consent was before this ruling, so I may be wrong.
Hi, Tracy Bailey. That was an excellent talk. Thank you. I am a lawyer. This is not legal advice. Call the CMPA if you need some.
Did I get anything dead wrong?
You got a few things, I would say, a little off, but not the last thing you say that the last question was about. I would agree with you. I think that's the result of the decision for end-of-life care in Ontario. Unfortunately, and I think a lot of the majority, a good portion of the majority decision was well thought through, but not all of it. They kind of worked their way through that boring technical stuff and got most of it right and hit the part they didn't like and said, well, that was all well thought through, but we don't really like the result of this, so this part we're going to assume wasn't well thought through, basically. So unfortunately, I think you're right on that. I do think it's limited to Ontario. I don't think, if interpreted properly, it should have repercussions across the country, and I think it's limited to end-of-life care. I think for the large majority of the cases you'll deal with, though, business will go on as usual. You usually reach consensus, etc. I think you're also okay where you have the case that you did with Mr. Azzulli, where you don't know of a prior express wish because you can go to the board, and hopefully the board will substitute a decision if they think that the substitute decision maker's decision was inappropriate. Where you're going to have a problem is if you have a prior express wish, and this may be where advanced care planning comes back to haunt you, because the board won't have jurisdiction to substitute a decision in that case. So I'm just wondering if you've got comments about the kind of the practical
Can I stop
implications of
CPR
that.
without consent? And why can't I?
Technically, yeah, you're withdrawing, right?
I'm asking
I agree
you.
with you. Well, they've basically said you need consent to withdraw care if it's part of a treatment plan, which they've encapsulated in treatment, which I would disagree with.
Sorry, let me just push you a little further because this is fun for me. One of the
Me too.
one of the reasonings was this argument about palliative care. Now, when I stop CPR, I'm not initiating palliative care. Does that change your mind?
I think you're quite right what you generally said, which would encapsulate stopping CPR. Technically speaking, I think you're right. It's captured. It's a horrible decision. It's an unfortunate decision. I hope that's not how you all end up practicing.
There's some disagreement in the audience.
Well, good. Well, we can have a chat after.
Okay.
It
makes sense to me. I just think it's an interesting.
I think you're quite right. The court, the two dissenters, as you say, are from Ontario. I don't think the court fully understood the implications of their decisions. I think they were worried about the ripple effects of their decisions. I think that's why they specifically said this is limited to this very narrow area. And unfortunately, even in this very narrow scope of practice of medicine in the province, it's going to, have a negative impact, I think.
I think we'll stop there. And I think, James, your question take
really quick. If this was we ran out of courts, and this is a very narrow statutory decision, is the next step to perhaps go to the legislature and ask for some more clarity to resolve those important questions that you asked?
I'm told, and I'm definitely not an expert on this, I'm told the Lieutenant General and the other modifications can be made that that don't require changes in the law. But I'm not an expert on this. That could be made at a regulatory level. But I think that'd be reasonable. I actually think, honestly, maybe I'll just get my last 2 seconds in. I don't have an issue with, in fact, many of us have just written a paper, a multi-society paper, that advocates a combination of scenarios where physicians are allowed, or the clinical team is allowed to make some decisions, but advocates a procedural resolution like the Consent Capacity Board. So I'm not allergic to that. The challenge for me is, as a non-lawyer, the reasoning in this decision is complicated enough to follow that I have as many questions. We went to the court to try to get clarity on issues, and I now seem to have more, withdrawing CPR, withholding treatments, et cetera. So those are my concerns, is that I feel a bit more confused in some ways than I did before. But thank you for the opportunity to speak, and thanks, guys.
Well, Gordon, thank you very, very much. That was very interesting. So that concludes our session, End of Life. Thank you very much, and we now transition to the next session.